All right, this first question is for Dr. Curtis. Why is it that a woman without a child, or how is it that a childless woman is at heart risk?
I think that's another one of those things that we don't really understand. I mean, obviously there are hormonal changes related to pregnancy. I mean, there's lactation, the child rearing. It's an observation that we don't have a clear-cut answer to, so I really can't go beyond that. It's just an observation.
Okay. This is for Dr. Witkowski-Wendy. And again, I'm just going to read the way it's written here. How does the rate of stroke or embolic events of women on birth control pills compare to the rates of postmenopausal women on hormone therapy? And also, in the studies that were done, were there any smokers included in the trials?
Okay. I can't quote the exact rates, but there are similar increases. We've known for some time that there are risks of pulmonary embolism and DVT in women who are on oral contraceptives, and also some increase in stroke, but the actual events are relatively small. In terms of smoking, the women in WHI at the time of enrollment were relatively small number of smokers, about 12%, which is lower than the national average, which is in this age group probably more like 20 to 25% overall. However, in terms of former smoking, almost half the women were former or current smokers. You know, there's lots of data looking at what we call effect modifiers. So was your risk of stroke higher if you also were a smoker, or you also had a high C-reactive protein level? We could not find anything that really explained that effect. We right now have a study called Garnet, where we're taking the women from the trial and doing a genome-wide association study to see if we could identify genetic characteristics that might identify those at higher risk of the negative events, because if what you could do is identify them, then perhaps those women that wouldn't have the negative events, it is more complicated. You know, initially we thought genetics we could explain a lot, but we are trying to look at that right now.
Okay, this next question is for Dr. Quatrin. Comment on the role of stress and high cortisol levels on abdominal obesity.
Well, I think Dr. Regala pointed to, to all of us the role of cortisol and that is produced when we are stressed. Now, cortisol, and I'm sure when you have dealt with patients who have to have corticosteroids therapy, it's also increasing appetite and potentially can lead to sort of, quote, more active adipose tissue. But the link between cortisol, stress, and what happens to the adipose tissue in the belly is also, it's difficult to evaluate because of the other issues related to stress. For example, the fact that most individuals, as a response to stress, tend to be binge eaters. But cortisol overall makes the adipose tissues more active to produce negative inflammatory factors, and increased cortisol makes us hungrier and hold on more to fat. So it makes people more predisposed to central obesity, but it's not the only factor.
This next question is for Dr. Regala. One of the individuals in the audience want to know examples of foods that decrease inflammation.
Anti-inflammatory foods are your omega-3 fatty acids or fish oil. So you should have 1 to 2 fish meals a week. And that would be fish meals not, it would be fish meals, say salmon, but not farm-raised salmon, but wild-caught salmon. There definitely is a difference in the amount of omega-3 fatty acids in farm-raised salmon as opposed to wild-caught salmon. Just think about it. In the farm-raised salmon, they're just being fed pellets of corn. I mean, they're not eating the algae and such that produces omega-3 fatty acids. So you can eat 2 to 3 fish meals a day, a week, and that would also be wild-caught salmon, herring, mackerel. And you could also take omega-3 fatty acid fish oil tablets. Also, fruits and vegetables will produce anti-inflammatory messages. So, basically, it's what you hear all the time. Less meat, more fish, more fruits and vegetables.
Okay, here's a question that I just received for Dr. Curtis, and so I'm going to read this. If I make a mistake, it's because this is the first time I've read it. The recent Barbara Walters special on heart disease and surgery, in the recent Barbara Walters special on heart disease and surgery, it pointed out that women's symptoms of a heart attack are different from men. For example, women do not necessarily experience pain traveling down the left arm as in men. Women may experience chronic fatigue. Any other different symptoms of a heart attack in men versus women?
That's an excellent question. The traditional signs that we think of with a heart attack are not just the pain going down the left arm, but squeezing, crushing, heaviness, that sort of thing. That's more common in men. Women often don't have that symptom. I wouldn't say chronic fatigue so much, because that's probably half the audience is like that, and you'll all go run into your car, the doctor tomorrow. But more like exertional shortness of breath. That can be one symptom. So symptoms that come on specifically with exertion would be something I would look for. And exertional fatigue out of proportion to what you're doing, I think, would be something else I would watch out for. Indigestion. I can still so clearly remember a patient from when I was an intern way back in New York many years ago, a Hispanic woman, so she couldn't speak English to anybody in the emergency department. She'd come in with indigestion, was diagnosed with, peptic ulcer, whatever, heartburn, sent out. And a week later she came back, and I think, we finally got an EKG on her, and she had had a heart attack. And it wasn't recognized because of the indigestion symptom. And that's classic with an inferior heart attack. But again, something that's unusual, something that's strong. But if you're not prone to that sort of thing, and now you suddenly get it for the first time, it's worth paying attention to. Sometimes people break out in sweat too. So sweat, nausea, indigestion, shortness of breath, all of those things, and you don't have to have any chest discomfort whatsoever, and it could possibly be a heart attack.
Okay. This one is for Dr. Quatrin. How does diabetes increase the risk for breast cancer?
Actually, having diabetes does increase the risk for breast cancer, and this is why, to me, was very surprising that as I reviewed the literature, women with diabetes wouldn't be receiving, undergoing mammograms at a higher rate than in fact are. The exact mechanism is not clear, but it's undoubtedly there. So it's most important that women who have diabetes have a mammogram, because also, although a lot of education should be placed in self-examination of the breast, that is, we pediatricians don't do a good enough job with that. So women grow up with this idea that it's not something that that they should be doing, and for somebody who has more of a weight problem, self-examination might be also more difficult to detect some anomalies. So the link is there. Mammogram should be done, and self-examination should be taught routinely. Another important fact is that for women who may have more of a weight problem, the issue is that self-examination is one thing, but also inspection, and that again is not routinely taught. It's taught much more in countries like North Europe, where preventative services are more important. So a woman should be standing in front of the mirror, looking at her breast, raising the breast, seeing if there is anything out of the ordinary.
The last question, again, for the sake of time, but our panel will be here for your questions later. There are actually two for Dr. Regala, and I don't know which one to pick because, well, okay, I'll pick this one. In what way does stress affect pain perception? Is it made more or less intense?
It can heighten pain perception. So if you think about it, people who have chronic pain will have increased cortisol, increased inflammation, and you actually then perceive pain stimuli at a heightened response. So when you have chronic pain, you're kind of in this vicious cycle. So you have chronic pain, you're perceiving more pain at a heightened response, you have more pain, and so now you have more chronic pain.